as well as being part of ad hoc MDTs convened to discuss complex patients that need urgent planning in relation to their care. And he also runs the high-risk obstetric anaesthetic clinic. He's assisted with national guideline writing and was part of the trial committee for Salvo, which is the largest trial investigating the use of cell salvage in obstetrics. He provides anaesthesia and sedation services for obstetrics and gynecology, as well for the infertility unit at the Birmingham Women's Hospital. He's also the EPR lead for the anaesthetic departments on both sites. And in his free time, he's come to speak to us today about what he wishes we knew about the shared airway. So the floor to you, James. Thank you for your time.
Thank you. Very kind introduction. Right, let's hopefully we are sharing. Thank you for the kind introduction. So my name's James Gagan. I'm a consultant anaesthetist in Birmingham. I've had a regular ENT list in my job plan for many years now, and Emma asked me during a lengthy case if I'd be willing to talk to you to provide some insight into the anaesthetic aspects of ENT surgery. The title she asked me to talk about was Mallampati and Mayhem, what we wish ENT knew about the shared airway and preoperative assessment. So I hope by the end of this talk, we'll have covered the learning outcomes there on the slide. Also, Emma and Mira were kind enough to humour me and ask for questions that you'd like answered prior to this talk as well, and I'll hopefully cover those during the session. So why does this talk matter? If I can take you back many years to when I was an anaesthetic registrar or one of my ARCP panels, I was asked why, as an anaesthetist, I bothered to go on a managing obstetric emergencies course. I had by this point decided to become an obstetric anaesthetist, and I said that one of the key rules of warfare is to know your enemy. Having done that course gave me a better insight into the competing pressures that obstetricians have. One might say I've taken that knowing the enemy a step further in that I've married an obstetrician. I'm not obviously suggesting you need to marry an anaesthetist to get a good view into the competing concerns of anaesthesia, but I'm hoping this evening's talk will cover some things that will make you a better surgeon because you understand anaesthesia a little bit better. ENT is a high-risk specialty for anaesthesia. An awful lot of ENT procedures for a site are not anaesthetically particularly challenging. Okay, the patients can be elderly, for example, those having cochlear implants, or they can have significant ischemic heart disease or lung disease in those with the smoking-related cancers that you'll see. But by and large, anaesthetically, they don't appear to be difficult in the way that, say, complex cardiac anaesthesia may be perceived. But notice that I said appear to be. Attention to detail is needed for many ENT cases because small things going wrong can end up with catastrophic consequences. And the concept of a shared airway is one of those things. If we make an error, for example, in a procedure where we need to do a tube change, and we've forgotten to put the patient on 100% oxygen prior to that tube change, they're going to desaturate incredibly quickly whilst you're struggling to place the tracheostomy tube. Equally, if we've spent ages intubating a very difficult airway and then you pull it out by mistake, that's going to cause us an awful lot of stress. So we share the airway and we share the consequences when things go badly. Some of the books and articles I was sort of reading in preparation for this talk were saying that anaesthetic priorities differ from surgical priorities. And that's sort of true, but I would actually argue our number one priority is always the patient and ensuring that at the end of the case, we've got a healthy patient. And in that regard, our priorities align. But there are things that we can do to make your life easier, and there are things you might ask us to do that could cause potential issues, and we need to tell you about them. So you might want a bloodless field and therefore a hypotensive anaesthetic, but if the patient's got significant ischemic heart disease, that's not really going to work. Now, obviously, I'm not going to turn you into an anaesthetist or a perioperative physician in the time available this evening, but there are some things you can think about when you're booking patients for surgery that can minimise delays. And if you can see things from the anaesthetic side, why certain things matter to us, you might be able to preempt some problems. So, anaesthetists are fundamentally simple creatures. When I'm presented with a tricky patient, I have a flow sheet with only two questions in the back of my mind. Can I make this patient fitter? Yes, no. And then, do I have time to make them fitter? Yes, no. That's one of the reasons I particularly enjoy obstetric anaesthetics, because the answer to question 2 is almost always no, which limits my options to crack on. So I've titled this slide, What Stops Us Anaesthetising? there's actually very little that will stop us anaesthetising someone. We will occasionally see letters or hear conversations, or the patient will say, oh, the surgeon said I'm not going to survive the anaesthetic. Barring airway mishaps, I've actually got to work pretty hard to kill someone. Most patients will survive even my anaesthetics. The issue is rather whether they'll survive the post-operative period or the surgery itself. And the underlying concept behind that is poor functional reserve. For major surgery, you're looking at about 6 months to recover, even if you're reasonably fit. If you're young, yeah, maybe 3 to 6 months, but in older patients, it could quite easily be a year, and some will never get back to their pre-morbid state because of such limited reserve. So there are things you can do to assess functional reserve for major or even minor surgery. Depending on the operation, there's more or less leeway. So someone having a panendoscopy worries me far less than someone having a laryngectomy with major dissection and radial flap. We can look at echoes, we can look at lung function tests, but one of the simplest things you can do is just say, can you climb a flight of stairs? So there's a concept known as METs, metabolic equivalent tasks. So one MET is you just sitting quietly doing nothing. Your oxygen consumption at that point is about 3.5 mils per kilo per minute. 4 METs is 4 times that, 14 mils per kilo per minute. And that's equivalent to walking up a flight of stairs slowly. And there's some reasonably good data on CPEX testing, looking at post-operative outcomes, that shows if your VO2 max is 11 mils per kilo per minute or below, your risk of perioperative events significantly increases. So if you can climb a flight of stairs, you've actually got a little bit of leeway. So when you're listing someone for surgery and thinking, this one might be a bit dodgy, do I need anaesthetics or medicine involved? Just ask them, can they walk up a flight of stairs? And if the answer is no, even with no other obvious medical issues, it's probably worth the referral because it signifies physiological frailty. And then depending on the surgery and the outcome of investigations, any MDT discussion may want to consider modifying surgery options or delaying surgery if possible to try and improve fitness. There are other things that may cause us to postpone surgery if picked up late. So it's not unusual that your anaesthetist won't necessarily know about many patients until just before surgery. And if someone, for whatever reason, hasn't triggered a specific anaesthetic clinic review and has only been seen by the nurses a week or 2 before surgery, that might be a problem. It's certainly not uncommon for me to get an email on a Friday at 4 o'clock telling me about a patient on my list on the Monday. Their blood pressure is this, what do you want to do? And at that point, my options are either cancel or don't cancel. I have no opportunity now to optimise or to investigate the patient further. Whereas if the issue had been identified 1 or 2 months earlier, it potentially could have been fixed. Recent guidance from the Association of Anaesthetists on Blood Pressure Management says that if a patient has a documented blood pressure of less than 160, 100 in the last 12 months, carry on. If there's nothing documented in the last 12 months, but in the pre-op clinic, it's less than 180, 120, we can carry on. Someone for surgery, just check the shared care record. Have they had a recent blood pressure check at the GP? If they've not had a blood pressure check, ask a clinic nurse to check the blood pressure. If it's sky high, 200, 130, and surgery's a couple of months away, there's time to intervene and optimise them. Either refer back to the GP and say, can you start them on some blood pressure management, or refer to a friendly physician in your hospital to try and optimise any medical management. Obviously, if the surgery is urgent and needs to be done in the next week, we're just going to have to grin and bear it and accept a more unstable anaesthetic course and carry on. One of the questions that I did get asked prior to delivering the talk was regarding blood pressure threshold. So I'm going to take a slight detour and cover that. I'm going to go back to your first year med school physiology. The brain and the kidneys exhibit a concept known as autoregulation. So what this means is that over a very wide range of blood pressures, the blood flow to those vital organs stays constant. What happens in patients with hypertension is that the limits are shifted upwards as the body becomes used to higher pressures. And the result of this is that a lower blood pressure under anaesthesia that might be okay for a healthy individual is actually dangerously low for a patient with pre-existing hypertension. And Hypotensive anaesthesia is beloved of many surgeons, including ENT surgeons. I've lost count of the number of times I'm asked what the blood pressure is. My usual response is, what would you like it to be? Hypotensive anaesthesia describes keeping the patient's blood pressure at a low level during surgery, generally lower than it is for normal surgery. And the benefits are it reduces blood loss. And there have been quite a few studies that demonstrate that. They are, however, mostly surgical in nature, and they generally didn't look at safety outcomes. There's not a huge amount of data looking at safety outcomes regarding hypotensive anaesthesia per se. What we do have, though, is increasing amounts of observational data that links inadvertent hypotension to myocardial and renal injury. And the consensus seems to be that a mean arterial pressure of less than 80 for more than 10 minutes is associated with increased risk of organ injury. And lower blood pressures are probably tolerated for less time. And in patients with pre-existing hypertension, the MAP thresholds probably need to be moved upwards. So this obviously means there needs to be a risk-benefit discussion about hypotensive anaesthesia on a case-by-case basis. If the surgery simply can't be performed without it, we need to do it. But if the bulk of the surgery can be done without it and it's only needed for a period of time, then that might be a better option. And there are actually other things that we as anaesthetists can do to help reduce blood loss and improve your surgical field. Blood loss isn't exclusively down to just blood pressure. High venous pressures can cause more ooze during your surgery. So things we can do with patient positioning, head up, we can try and tweak our ventilation settings to reduce airway pressures. We need to be ensure that our tube ties aren't particularly tight and causing a bit of venous constriction in the head. And that can all help reduce your venous ooze, improve your field without necessarily needing to drop the blood pressure quite as much. Alongside questions about low blood pressure threshold, there was also one about high limits. This isn't generally an issue under anaesthesia. The pre-op upper limits I've mentioned earlier. High blood pressure under anaesthesia may be a sign of intraoperative pain or awareness, so anaesthetists are generally pretty quick at jumping on that. I try not to let the intraoperative blood pressure go above pre-op levels for that reason. Intermittent brief periods of high blood pressure are common during some procedures, things like panendoscopies, where you're putting your laryngoscope in and out and lifting, and that can get some fairly impressive surges for short periods of time. Sustained hypertension, though, can be associated with cardiac events. I've had a case where adrenaline was infiltrated rather than local with adrenaline, and the patient's blood pressure actually went off the scale, and they had significant ST changes on their ECG. We ended up cancelling that case just to wake the patient up and make sure they'd not had a stroke. If we come back from our little detour and go back to some other pre-op considerations, poorly controlled diabetes can be an issue. So there's been recent guidance to suggest that if their HbA1c is above 69, we need to consider, is there time to improve control? So HbA1c is 90, surgery's in 3 months. Can we try and optimise it? That's probably worth a referral to the diabetologists. If somebody turns up on the day and we discover they've got an HbA1c of 90, we're probably not going to cancel major or cancer surgery. But day case surgery that's elective will probably be postponed because poor control increases your perioperative risks. Your wound healing is worse, you're more likely to get cardiac events post-operatively. And obviously there's an element of discretion here. It may well be that an HbA1c of 90 is actually the best this patient can manage. They are as optimised as they're going to be. Other uncontrolled diseases may need sorting ahead of surgery. So if someone's got angina at rest and the surgery can wait, please refer them to cardiology whilst you're listing them, even for simple cases. As I said, a panendoscopy, you get repeated laryngoscope insertions causing surges in blood pressure, and that can cause a strain on the heart in someone who's got unstable cardiac disease. If the patient's anemic and they're having major surgery with bleeding risk, refer them to haematology or peri-op medicine for an iron infusion. If they've got uncontrolled thyroid disease, ask your endocrinologist to tweak their medication before we move to multinodular goiter. You guys see these patients long before we do, and thinking beyond that, the anaesthetist will sort it, and that can improve your outcomes, but it will also reduce your cancellations on the day. BMI thresholds I've popped in brackets. BMI per se is unlikely to cause you to cancel somebody, particularly for the ENT cancer surgeries. But what is worth thinking about is obstructive sleep apnea. So I've borrowed that table from a BJA education article just because it was the first one I could find that listed everything nicely. So there's a quick questionnaire called Stop Bang, so S for snore, T for tired, etc. And if the patient answers yes to 3 or more of those questions, they probably merit referral for sleep studies if the surgery is elective and the patient hasn't already had sleep studies. Obstructive sleep apnea is associated with pulmonary hypertension, increased risk of stroke and adverse cardiac events, and also respiratory depression post-operatively. And that can often be relatively quickly fixed by starting the patients on CPAP and obviously advising about diet and weight loss. Nil by mouth. Fasting, please note that term, it's not starvation. Fasting is a particular concern in ENT, especially with shared airway cases. They're technically not nil by mouth because we allow them to drink. Patients are required to be fasted for surgery primarily to prevent aspiration. So this is where food and liquid enters the lungs during anaesthesia, which is, you've got a reasonable chance of them needing to go post-operatively to ITU for some overnight ventilation. Whilst under anaesthesia, your normal reflexes that prevent aspiration are obviously reduced. And the risks of aspiration can be airway blockage with solid food. That makes it difficult for us to ventilate the patient, obviously. Lung infections, so the inhaled substances can cause infection in the lungs, causing a post-op pneumonia. But you can also get a chemical pneumonitis just from the acid irritating the lung linings. And also a full stomach increases the likelihood of vomiting during or after the surgery, which can complicate the procedure. So if you spent ages with your delicate anastomosis, you probably don't want your patient vomiting post-operatively. And over the years, the limits for fasting generally got more permissive, and in many places they run with sip till send. So 6 hours for solids, 2 hours for clear liquids, and then from 2 hours up until the point of sending for the patient, they can have sips of water. We run with 170 mils an hour. That's apparently a standard NHS cup. The clear fluids, if you've got a sensible patient, you can say have black tea, black coffee, nothing fizzy, and you can have squash. It doesn't have to be water, but nothing with particulate in, so you can't have your fancy orange juices. You are technically all right with a small amount of milk in your tea or coffee, but you know that as soon as you say that to the patient, they're going to go and have a cappuccino or a latte. So I just tend to just say black tea, black coffee. The use of gastric ultrasound is becoming more widespread. We're finding more and more patients are on GLP-1 antagonists, which help with weight loss, but they unfortunately delay gastric emptying. So your fasting period may need to be longer, or the patients need to stop their medication well in advance of surgery because some of them got quite a long half-life. But then that carries its own problems for their blood sugar control. So many patients are on the GLP-1 antagonists for blood sugar control. And recent guidance is suggesting a pragmatic approach, which is continue on with your normal medication, but if you're worried, gastric ultrasound the patient to see if they've got a full stomach. It's not something I routinely use. I'm not skilled in using it. There's a bit of a push for using it within obstetric and paediatric anaesthesia as well. So I suspect it may well end up being something I'll need to learn. Obviously, we can manage a patient with a full stomach. We do it for emergency procedures. What we do there is what we call a rapid sequence induction. We try and limit the period of time between loss of consciousness and a protected airway with an ET tube in. But this does carry some risks if there's then a failed intubation. So it's not really something we're keen on doing in someone that's a particularly tricky case. With a shared airway case, on top of the food, there's an increased aspiration risk because the tubes are going to be moving and you're going to get micro leaks around the cuff, on top of which we've got blood in the airway from the surgery. So, for those cases, if the patient isn't fasted, they're going to be delayed or possibly cancelled. You see the patients earlier than we do, so reinforce the nil by mouth instructions, especially to parents of children having their things like their grommets and stuff like that. Also, don't change the order of the list. If we told someone they can have breakfast and then you want to move them to an 11 a.m. slot, that's not going to work because they'll have had breakfast at 6. So there's going to be a hold up in your list. ENT surgery and MAXVAC surgery have specific concerns for anaesthesia because of the shared airway. We want it for oxygenation, you want it for the operation. If I'm doing a gynae list and my ET tube comes loose, it's a nuisance, but I can usually re-intubate the patient, carry on, and the surgeon's probably not even noticed that the tube's coming out. If you're operating around the head and neck, that's obviously not an option. If you've got the neck open, you're not really going to want me manipulating to re-intubate the patient halfway through your procedure. And if you've got gags and scopes in place, that's going to delay things. And if we're doing robotic surgery, that is a major issue. Undocking the robot is something that the team need to drill for. And there's actually a limited pool of anaesthetists that actually do robotic surgery for that reason, because it's such a big deal. So we want to be certain the tubes stay in place. So I need to be meticulous about securing the tubes. You guys need to be careful when manipulating the head and neck so we don't dislodge them. Hold my hand up. I've had a tube come out partway through a thyroidectomy. That was my fault. The tube hadn't been tied quite firmly enough, and the tube thyroid was so massive that as it came out through the neck, the thyroid was able to sort of expand a little bit, and then the trachea, which had been so squashed, opened up a little. And then there was less pressure holding the tube in place, and it just gradually slipped out under the weight of the circuit. And that was entertaining, trying to re-intubate that patient partway through. Fortunately, my ENT surgeon was a very good communicator and just said, well, I can see the trachea, I can do a tracheostomy if you like. So we did a very quick tracheostomy, popped an ET tube in through there, and then that bought me some time to re-intubate the patient. If you're operating in anywhere in the body, there's going to be swelling and reactive edema. So in the airway, that's a bit of an issue. We routinely give dexamethasone as an antiemetic, but it'll also help reduce airway swelling. Post-operatively, particularly with a lot of oral and nasal surgery, there's going to be bleeding. We're obviously going to suction stuff out, but we'd like you to give a good hoover out as well before we wake the patient up. If there's a large clot sitting in the nasopharynx and we extubate the patient's going to take a deep breath in and they'll suck down on that clot, and that'll cause an obstruction, hence the name coroner's clot. There are things that you can do that will worsen or improve airway safety. And in terms of planning and preventing problems, you can give us early warning there's an issue. If you've done a nasendoscopy in clinic and you can't see the cause because the supraglottic tumour is so large, or the laryngeal tumour is extending over and there's barely any room for a scope, tell us, because we want to know about that. And you can also flag imaging that we might want to review. It often comes up in the team brief, but if an anaesthetist and a surgeon work together regularly, they'll often email ahead of time. So on the morning of surgery for complex cases, we'll plan, this one needs an O8 fibre optic, this one needs jet ventilation, or after discussion we may say, actually, this is going to be an O8 trachea. And at every stage we need to have a get out, we need to have an escape plan if the primary approach fails. And that's got to be communicated to the whole team and is a joint surgical and anaesthetic decision. So there are things that you can document in clinic that are incredibly helpful for us. So my ENT list is on a Monday. I'll prep my list the night before. So on Sunday evening, I'll go through letters, results, bloods and scans. And one of the most important pieces of information that I go to first is the last clinic letter explaining the problem and why we're operating. And if someone's actually documented an airway assessment and they're finding it's incredibly helpful to me because I'm already in the right mindset and I'm preparing for my conversation with the patient. I said earlier, I've married an obstetrician. I've actually trained her now to recognise potentially difficult airways in antenatal clinic. Because if we're doing a general anaesthetic in obstetrics in the middle of the night, we do not want a failed intubation. So she'll often flag patients antenatally and ask us to see them. And there are certain things that should be raising red flags for you guys that are going to be problems for us. So whenever we assess an airway as part of our pre-op assessment, we're having at the back of the mind, can I oxygenate this patient safely? Can I ventilate them safely with a bag and mask? And can I intubate them safely? And if the answer to any of them is no, alarm bells are ringing and we need a different plan. Now, generally speaking, oxygenation is not a major concern. Severe lung disease may limit oxygen reserves because of low functional capacity. Ventilation may be difficult. If they've got a beard, if they've got no teeth, if they've got thick neck, if they've got obstructive sleep apnea. So those things, when we see them, we're sort of beginning to think, okay, this might be a bit tricky. We can assess ease or otherwise of intubation with the Mallampati score. So we ask the patient to open their mouth and stick out their tongue. And depending on what we see, we can score the patient 1 to 4. Mallampati score 1 and 2 is associated with easy intubation, 3 and 4 with difficult intubation, but it's not a direct association, and it's poor at predicting mask ventilation. There are some other things we look at. We look at the thyromental distance, so distance from thyroid cartilage to the mentum. Normal distance is 6.5 centimetres, less than 6 centimetres, so about 3 finger breadths, is associated with difficult intubation. We assess neck mobility. So if the patient can't fully extend their neck because of arthritis or radiotherapy, that's concerning. That's probably my single biggest concern. Now, having done ENT for a while, I'm reasonably happy with most sort of airway things. If you can open your mouth enough, I can get a laryngoscope in, I'm generally happy. If you've got a bit of a beard, I'll manage. If you can't move your neck, that worries me. Very limited mouth opening from TMJ dysfunction or abscesses or tumours. That makes it harder for us for our rescue with something like an LMA. So again, that's ringing alarm bells. And combining all of these things together is quite good at predicting difficult intubation. Another test we can do is called the upper lip bite test. So you just ask the patient, can you bite your upper lip? With their lower teeth. And if they can't, it means they've got a bit of an underbite, they've got a shorter mandible, and that's also associated with difficult intubation. So if you, in your clinic letter, have said, yeah, such and such are having this operation, and then you put, they've got a Mallampati score of 3, they've got 2 finger mouth opening with limited neck extension and a large tongue-based tumour, I'm already thinking this is going to be a problem, and I'm prepping for that conversation ahead of time. I'm in the right mindset to be thinking difficult intubation, difficult airway. So if someone is otherwise fit and well, but has what you think might be a difficult airway, flag it up. Your anaesthetist will be delighted to see that. And if you're really worried, ask an anaesthetist if they can just stick your head into clinic, because there'll often be there'll often be an anaesthetic clinic running in outpatients somewhere, and you might just be able to get someone to cast an iron over their airway. When we're sort of on the day of surgery, we need to have really good communication between surgery and anaesthesia. So at the team brief, tell us what size tube you want, what side of the mouth you want. Do you need nerve monitoring during the case? If that's the case, we'll give a slightly smaller dose of paralysis for intubation. Are there periods where you must have an absolute stillness? In which case we'll ensure we've got top-up doses of paralysis immediately available. We need to tell you, what we need to do is tell you if we've got discovered any pathology that might make prolonged apnea times difficult. So morbidly obese patients desaturate very quickly if we're not ventilating. Pregnant patients desaturate quickly. Slightly less relevant for ENT, but there are some conditions where we would prefer not to paralyse the patient. Modern drugs and reverse-agents make it less of an issue than, say, 15, 20 years ago. But if we've paralysed the patient, even with a small dose, the nerve monitoring might not work properly in certain conditions. And even after reversal, there may be some residual weakness. So that's just something to bear in mind. Intraoperatively, probably the commonest problem is who's disconnected my tube. And we just need you to pause while we fumble under the drapes and reconnect everything. Tell us if you're going to move the head, and we can keep an eye on the airway pressure. We can check, is the patient beginning to breathe over the ventilator with that stimulation? Are we going to need to reparalyse them? We need to tell you, are we struggling to ventilate the patient or oxygenate the patient, particularly with jet ventilation? If we're needing very high jet pressures, we need to tell you and possibly switch back to conventional ventilation. If the patient's cardiovascularly unstable, either their underlying condition or there's significant blood loss, we'll tell you, can you check everything's okay on your side? Because when you're looking through your loops, you have a very limited field of view, and if there's ongoing ooze that's just soaking into the drapes, there's actually, you simply won't see it because your field of view is so narrow through the loops. And we also need to have decided pre-procedure for the complex cases what we're going to do when the problems occur. If this, then this, if that, then that. And the robotics team will have that planned out, will have planned out roles, who is going to do what during the case if something goes wrong. And everyone needs to know what's happening. There are a couple of questions about how we manage patients for tubeless surgery. So you might wonder, well, if you can deliver anaesthesia without a dedicated airway, why not just not bother intubating everyone for upper airway surgery? I mean, your life would be a hell of a lot easier if you didn't have an ET tube in the way, wouldn't it? Unfortunately for you, tubeless surgery is not a magic solution. It's actually quite a risky technique. Indications for it would be if the tube's going to obscure the surgical field, if you need subglottic or hydrochaeal access, or the pathology is just below the cords. It's designed to make the impossible possible. It's not there to make the difficult easy. There are two main types of oxygenation strategies for tubeless surgery. There's either high flow nasal oxygenation and there's jet ventilation. So high flow nasal oxygenation applies a constant airway pressure, so like CPAP, but it's just through the nostrils. So it's humidified oxygen going at high flow. And what this does is it keeps the individual alveoli open in the same way that if you blow up a balloon and then you can keep it inflated by just applying a continuous small amount of pressure at your mouth rather than just tying it off. There's high concentration of oxygen, therefore, in the upper airway, and then you get bulk flow of gas down that concentration gradient where it's taken up from the alveoli into the bloodstream. But because there's no true ventilation, carbon dioxide is not breathed out and will accumulate over time. And carbon dioxide accumulation is associated with acidosis, tachycardia and arrhythmias, pulmonary hypertension, and increased cerebral blood flow. And in the presence of hypotension, hypercapnia, high CO2 levels, actually increases your relative risk of stroke and postoperative cognitive dysfunction. There was a retrospective analysis of some laser-laryngeal surgery cases where the primary oxygenation strategy was apneic high-flow nasal oxygen. And despite the oxygen saturations not really dropping very low and a mean apnea time of almost half an hour, nearly half of all cases required conversion to alternative ventilation intraoperatively. And obese patients and patients with hypertension were significantly more likely to require that conversion. Some of the issues related to CO2 accumulation can be mitigated by allowing the patient to breathe spontaneously during the surgery, i.e. we haven't paralysed them. But that carries its own problems for you guys if you're doing delicate surgery on the vocal cords, if they're going to be moving or if the patient's going to be coughing intraoperatively. With jet ventilation, we apply intermittent high pressure bursts of gas into the airway, and it's usually at a frequency approaching physiological breathing rates. High frequency jet ventilation is used in ITU. How it works, we're not entirely sure. There are some mechanisms which are proposed. There is a bit of bulk flow, just you're squirting an element of gas down the airway. But there's things like laminar flow, convective streaming, molecular diffusion, pendular cardiogenic mixing, which I once understood when I was revising for my FRCA, but the exact details escape me at the moment. I could probably have a stab. But Which one works in which situation, we're still not entirely sure. So, as I mentioned, tubular surgery is not risk-free. So high-frequency oxygenation, high-frequency nasal ventilation and jet ventilation will oxygenate the patient. They won't clear CO2, short periods, not a major problem, but you are limited to about half an hour. It's difficult for us to assess the adequacy of oxygenation as well until the sats start to drop. So we give 100% oxygen with the nasal flow, and that generally does give high inspired concentrations of oxygen. But with jet ventilation, we're squirting in 100% oxygenation, but we're in training room air. So the amount of oxygen that the patient gets is a little bit unknown. If we're doing translaryngeal jet ventilation, where we're through a catheter that's gone through the cords, that can quite easily become obstructive. And you can then get very high pressures, or it can get displaced if you move the neck, the head and neck. And that can then cause damage by delivering high pressure oxygen to the wrong place. The jet ventilation also depends on high pressure air going in, but then passive egress. So if there's airway obstruction, the pressures can build up and you can cause barotrauma. So it's possible to pop alveoli in the same way you can pop a balloon, and that will give you a pneumothorax, pneumomediastinum, or surgical emphysema. So that means, as well as you guys performing the surgery, you've also got another role, ensuring the airway stays patent so that air can escape. And then on top of this, there's no protective airway, so the risk of aspiration is significantly increased. So what we want from you is you need to say why you need a tubeless field, and then we need to agree what our strategy is going to be. Is it high flow nasal oxygen? Is it going to be jet ventilation that's supraglottic, transglottic, or transtracheal? But we both need to agree what we're going to do if it fails. As I said, if we're using a catheter, please don't move the head and neck once we've confirmed it's in the right position. You may have come across your anaesthetist getting excited about awake fibre optic intubations, a bit of an anaesthetic party trick, but we do need some help from you guys, really. If you can tell us the most recent nasal endoscopy findings, that's incredibly helpful. Now, your view in a sitting awake patient is very different from ours in an asleep patient. If you don't believe me, you can always ask your anaesthetist if you can have a go doing an asleep fibre optic intubation. But if we're doing an awake fibre optic intubation, the view that we'll get is very similar to what you'll have seen in clinic. So if you can say, yeah, there's a large bulky tumour in the hypopharynx, but actually once you get around it, you're going to get a beautiful view of the cords, that just gives us a little bit of reassurance. If you think that the airway obstruction is so critical and the patient may not tolerate sedation, that does affect our plan and our conversation with the patient. Romifentanil has made life a lot easier for awake fibre optics. We don't need as much sedation. It's very reversible, but it's still useful for us to know. And if there are concerns, we may ask you to be scrubbed and ready to do an awake tracheostomy. So I had a case last month, 6 weeks ago, where I'd anticipated, it might be a little bit tricky to bag and mask this gentleman. It was potentially going to be a difficult area, but I thought I'd probably be okay. But my surgeon said, actually, this tumour on the last day's endoscopy, it's really, really bulky. It's going to be really difficult for you to intubate it. It's great. I just got another consultant to come and give me a hand. We did a 2-consultant anaesthetic, and sure enough, he was difficult. With conventional laryngoscopy, we had to do an asleep fibre optic. Doing an awake tracheostomy, that's not failure of airway management. That may well be the safest option. And indications for that would be critical supraglottic obstruction, distorted airway anatomy, where the tumour is so big that the space through the cords would mean that if we put a fibre optic scope through the cords, which we need to do to then pass the ET tube, we're going to obstruct the airway. It's what's called a cork and bottle effect. If the tumour is incredibly friable, supraglottic or hypopharyngeal tumour, it's really easy just for a few drops of blood to totally obscure the view, and we then can't do anything. And if the patient's got severe stridor or arrest, that's usually a bad sign and probably an indication for an awake tracheostomy. If you tell us early and honestly, I don't think you're going to be able to intubate it. It's very helpful. If you think it might be possible but difficult, it's not a problem. We can do it in theatre. You can prep your neck, mark your landmarks before we start, and you get scrubbed and ready with a tracheostomy kit. We attempt the intubation in theatre, and if we're struggling, we just go to a tracheostomy. There's a couple of slides that are coming up now that deal with some of the questions I got that didn't really sort of fit into the flow of the talk, so I sort of put them together at the end. So one of the questions I asked was, why is remifentanil so important in ENT surgery? So remifentanil, Remi for those in the know, is a synthetic opioid. It's very potent, and it's ultra short acting. It's got a half-life of a few minutes. Okay, so you can achieve profound analgesia quickly. It also wears off very quickly, and is incredibly titratable. Now, as well as being analgesic, opioids generally are antitussive, so they make you cough less because they obtund your airway irritation reflexes. Codeine used to be included in cough medicines for this reason, and remifentanil causes profound suppression of these reflexes. So why is this important? Well, if you don't want the patient to be paralysed because you're doing nerve monitoring, we can just do a very small dose of paralysis for intubation, let the paralysis wear off, safe in the knowledge that just minor tube movements during the surgery are going to be well tolerated. The patient's not going to cough, whereas if they weren't on Remi, they probably would be. We can use that, as I mentioned, for our awake fibre optic intubations. The patient tolerates the airway manipulation. It covers if our local anaesthetic spray has been less than perfect, and we don't need as much sedation. And if we run into problems, we switch it off and it's worn off in minutes. It also allows for quite good blood pressure control without the significant cardiovascular depressant effects of most of the anaesthetic agents, which makes it great for you guys if you want high potential anaesthesia. And because it's very titratable and there's very profound analgesia, we don't need quite as much of a deep anaesthetic. And therefore, as a result, our patients generally wake up quickly with very rapid restoration of their airway reflexes, hopefully without coughing. So that's great for you guys, where there's, you've spent an awful lot of time doing some delicate neck surgery. You don't want your patient coughing and bucking on the tube when they wake up and then getting a neck hematoma. Also, ENT surgery, a lot of blood, a lot of secretions. We want the airway reflexes firing at the moment we pull the tube out. So by obtunding all of the reflexes during surgery, it makes tubeless surgery more straightforward as well. So for the tubeless surgery cases, we'll run them on a remifentanil infusion and then propofol infusion for the anaesthetic side of things. Pregnancy, I think the picture on the right is probably what most surgeons think of when they see a pregnant patient that needs surgery. Surgery in pregnancy is not rare. About 1% of pregnant patients will need non-obstetric surgery during pregnancy. Urgency leads. Okay, don't delay necessary surgery just because of gestation. But if it's non-urgent, second trimester is preferred. But please, please, please do not make a decision on treatment without involving an obstetrician. The number of cases where, as a maternal medicine network, we've had to unpick conversations because somebody's mistakenly told the patient, oh, you can't have this surgery because you're pregnant, or you can't have this chemotherapy, you're pregnant. That's wrong. If you're having an MDT about a case and the patient's pregnant, include an obstetrician. Surgery in pregnancy is a bit more difficult. Pregnancy does cause some physiological changes, which I suspect half of the audience are probably aware of. It reduces your oxygen reserve. You are going to desaturate more quickly. You are more likely to aspirate. Your hemodynamics are different. You get changes in a number of your plasma proteins, so your drug binding is different, so the effects are different, and you have a very, very high VTE post-operative risk. Post-surgery, monitor for preterm labour. Please, please, please ensure the patient has got thromboprophylaxis. Your anaesthetist will hopefully be giving multimodal analgesia. But you can reassure your patient that most agents are compatible, most analgesic agents are compatible with breastfeeding, with the usual exception of choline. But also acknowledge that the patient is going to have a psychological impact from having surgery whilst pregnant as well. The sort of bottom line is everyone worries about the baby, and pregnancy is kind of the last bastion of paternalistic medicine where it's alive and kicking. But actually, if you look after mum, you look after baby. So related to that, we've gone from telling women with significant medical disease, you should never get pregnant. And we're now telling them, we don't advise you getting pregnant, but we will support you if you do. And as a result, more and more women with complex medical problems are getting pregnant. NHS England published a service specification for maternal medicine networks to improve care for these women. The one in the West Midlands is based at the Women's Hospital. We're actually the only network that's got funding for anaesthetic presence at the MDTs. This isn't part of the national specification, but our insightful obstetric lead for the network, my wife, recognised the need for our input and lobbied for funding. So clinicians from other units can refer patients to us via an online portal. And we see patients with complex cardiac, renal and hematological disease. But for cases like complex ENT cases, we'll often set up an ad hoc MDT. We'll get the ENT surgeons, we'll get the relevant anaesthetists involved, the relevant obstetric physicians, we'll get the oncologists involved, and we can put up an ad hoc MDT together pretty quickly. I've included some links for our network. Other regions will have their own network links, and there's a couple of QR codes for some useful resources for drugs in pregnancy as well. So, what can you do tomorrow in your ENT clinic? Think ahead. Do you think you can get this patient fitter, and have you got time to get them fitter? And if so, refer them on. Is this patient a tricky airway? Not sure, maybe. I'll write down my findings. It'll make your anaesthetist very, very happy. If you've done a nose endoscopy, document your findings as you would do normally, but also have at the back of your mind, the anaesthetist might be interested in this bit, and put that down. And if in doubt, your surgeon knows who your regular anaesthetist is. Pick up the phone to them or send them an email, or contact the anaesthetic department and say, who's going to be anaesthetising on this day? And let your anaesthetist know in advance. I do not mind being phoned or emailed to have a quick discussion about a patient. I'd much, much rather know a month in advance that there's a complex patient and I can say, yeah, we just need to get this done. And if they're all okay, we're fine. Then find out on the day of surgery how they've got this problem. And then we're in a very difficult situation then about either proceeding, risky scenario or cancelling. So think ahead. Has anyone got any questions?
Amazing. Thank you so very much. That was absolutely brilliant. And I pinky promise my clinic letters are going to be so much better after this. You'll have a full, proper documented airway assessment. It's really good. Just whilst we're waiting for some of the questions to come in, if you can put them all in the chat, that would be really helpful, or raise your hands. I just thought I'd sneak in with a couple of questions if that's okay. So I distinctly remember we were operating and I overheard you teaching the lovely little SHO that came in about what constitutes a good anaesthetic. So just in your kind of own kind of word, okay. What very briefly, what makes an anaesthetic good?
Stability, I would say you can sum it up by. So I suspect you have similar scenarios for your sort of final exams as well. So you're presented with some bizarre case, how are you going to manage this? And it's always, I do this. And, there's sort of, when you've got through it, it's just, I'd give it a good anaesthetic. A good anaesthetic is avoiding hypotension. It's avoiding hypertension. It's avoiding low oxygen saturation. It's keeping the side just right, not too high, not too low. So appropriate ventilation. It's not letting the ventilation pressures go too high to potentially cause damage. It's basically Goldilocks. You want everything not too much, not too little, just so. And if you can achieve stability, that's probably the good anaesthetic. And I have to say, remifentanil smooths out an awful lot of bad anaesthetics and makes them good.
No, that's
stability.
really helpful. And then I really liked your point as well that I hadn't really thought about before, about actually they don't need to be hypotensive for the entire duration of the operation. So I was thinking to our thyroids, and say, for example, when we're getting kind of close to the nerve, how much of a advance warning do you need before we need to say we'd like this to be as bloodless as possible now?
5 to 10 minutes.
Oh,
probably.
Perfect. Superior pole, you're done.
Rami works pretty quickly in lowering the pressure. A few minutes. And we can just bump up the Remi. It'll give a small bolus and the pressure will drop. I'm normally running with a sort of systolic around about 100 for someone who's not pre-existing hypertension. I can drop it down to 80 for a little bit reasonably quickly.
That's really good. I suspect we've probably captured a lot of the questions by before the lecture, asking people to complete that form. Oh, that's so lovely. So Nor's just said no questions, but really useful to know about the maternity network. So thank you for that. We've had a few kind of complex thyroid patients where we've kind of made use of that, talking with obstetrics and endocrinology, ENT and anaesthetics, and it's just made everything so much smoother.
Yeah, I mean, we had one with we have a few with that had avial malformations subglottic that needed ballooning because they were obstructing. Kind of at about, I think it was about 30 weeks. And, I'm going in with my ENT and my obstetric hat on, and I'm getting quite anxious about aspiration risks at that point. And the surgeon was saying, it's fine. I've got a great big scope down there, and it's occluding most of the airway, and the suction through that is going to be fine. It's going to be past it. I will be able to suction up an awful lot of stuff if there is any sort of passive regurgitation. And that was actually quite reassuring for me, because I was thinking, well, where you're going to need to balloon is actually a little bit below the cords. You could probably do it through an ET tube. I've bronched patients on ITU. And he was actually, well, yeah, but if I don't have that, I can actually do the procedure in 5 minutes rather than in 25 minutes. And actually your aspiration risk is lower. So it is low anyway. So it was really helpful discussion, actually.